The first phase of pharmacokinetics for drugs given via any route other than IV is going to be absorption. Here's the objectives, which you can read, but I wanted to point out that you may need to calculate an IV or oral dose given the F, or calculate F if you're given the AUCs or doses. How do we get drugs into the body? Well, in order for a drug to produce a systemic effect, it must first reach its site of action, usually delivered through the bloodstream. In pharmacology, the lumen of the gut and the inside of the bladder can be considered outside of the body. Parenteral routes are those that bypass the enteral or GI system. Intravenous administration provides instantaneous access of a drug to the circulating volume. Other routes of administration require absorption into the bloodstream. Transdermal delivery generally takes the longest, followed by oral and rectal delivery. Subcutaneous, intradermal, inhaled, and intramuscularly injected drugs usually have rapid access to circulation, though there are sustained-release intramuscular dosage forms. The textbook demonstrates different routes with percent bioavailability in Table 3-3. Again, bioavailability refers to the amount of drug available to systemic circulation when administered by a non-IV route. By definition, the IV route has 100% bioavailability. Continuous IV infusion, as seen at left in the diagram, usually ordered in 1,000 milliliter IV bags as electrolyte solutions with or without added medication. We often talk about the rate of infusion in milliliters per hour. IV piggyback or intermittent IV are smaller volumes containing drugs ordered periodically, for example every 6 hours. They're usually piggybacked to run in conjunction with continuous infusion. The amount and type of diluent, which is the solution in which the drug is dissolved, is going to depend upon the solubility of the drug, the stability of the drug, and the irritant nature of the drug. Some meds can be given as a bolus or IV push, which means that they're injected rapidly into circulation. The rate is going to depend upon the nature of the drug. All three of these IV routes allow for 100% of the administered dose to instantaneously access the circulation. Bioavailability, the amount of drug available via non-IV route, measured as area under the concentration versus time curve, or AUC, compared to the AUC for the IV route. We use the F factor to express the ratio. AUC via route X divided by AUC via IV route is F. There are factors that affect F, such as first-pass metabolism, that we'll talk about soon, solubility, absorbability, stability of the drug, and formulation of the drug delivery. The upper graphic A demonstrates a concentration versus time curve after single oral dose administration. Note that some time elapses before Cmax. This indicates an absorption phase consistent with non-IV administration. The dashed line labeled MEC is a minimum effective concentration. When drug levels are above this line, there is sufficient drug to produce the effect. The time above the MEC is the duration of drug effect. In the lower graphic, we see two AUC curves, one for IV, instantaneous absorption labeled AUC IV, and the other for the oral route, AUC oral. The bioavailable fraction of dose F is calculated by dividing AUC non-IV by AUC IV. Take morphine for example. A typical IV dose of morphine is 10 milligrams, while the corresponding oral dose required to produce the same AUC is 30 milligrams. Thus, the F for morphine is 0.3, indicating that only about a third of the oral dose makes it to systemic circulation, where we actually measure drug levels. Therefore, we got to administer 3 times the mass of morphine orally to achieve the same total serum concentration over time as an IV dose. The formula to interconvert IV and oral doses with regard to F is desired oral dose equals the IV dose divided by F. Many factors can contribute to the loss of oral drug prior to its access to systemic circulation. Incomplete dissolution, acid instability, ionization-related and hydrophilic restrictions to diffusion, digestion by enzymes, delays in gastric emptying time, adsorption by foods or other concomitantly ingested substances, efflux pump export, enzymatic degradation in the gut, and enzymatic degradation on first pass through the liver may all reduce the AUC for oral drugs. Anatomy connection: which vein delivers orally administered drug to the liver before the drug can get to systemic circulation? The answer: the portal vein. Note that the pH of the GI tract changes so that drug absorption may differ throughout the tract due to ionization-related changes in diffusion. Cytochrome oxidase P450 enzymes are metabolic enzymes that usually increase the body's ability to excrete drugs via increasing hydrophilicity. There are several families of these enzymes. CYP3A4 is one member of the 3A family that's responsible for the metabolism of many drugs. Grapefruit contains a component, naringenin, that blocks or inhibits the activity of this enzyme in the intestinal tract. Therefore, meds, for example some of the statin drugs for cholesterol, that are normally metabolized by this enzyme in the gut can reach toxic levels when grapefruit juice is consumed. It's important to note that the juice is more likely to contain substantial quantities of the 3A4 inhibitor than is fresh or canned fruit. This graphic demonstrates the first pass loss of drugs as they are presented to the hepatic enzymes. Some drugs undergo rapid and avid metabolism by the liver. These drugs are said to have a high hepatic extraction ratio and undergo flow-limited metabolism, where the drug is degraded as quickly as it can be delivered to the liver by the bloodstream, both on the first pass through the portal vein, but also after access to systemic circulation through the hepatic vein. Other drugs that undergo metabolism in the liver may be metabolized by slow enzymes or enzymes with limited capacity. In this case, the enzyme system may be operating at maximum capacity. Changes in delivery of drug to the liver, due to changes in blood flow, for example, won't impact the rate that the drug is metabolized. These are known as capacity-limited drugs. Other drugs don't even undergo hepatic metabolism at all. To calculate the hepatic extraction ratio, if you care, subtract the drug concentration out of the liver from the drug concentration entering the liver, multiply it by the blood flow, Q, and divide by the concentration into the liver. A ratio of 0.8 or more is a high extraction ratio drug and indicates flow-limited metabolism, while a ratio of 0.3 or less indicates that capacity-limited metabolism is more likely. Some oral drugs are formulated in a sustained release dosage form, either to limit exposure to harsh stomach environment and or to slow absorption. A suffix in the drug name such as CD, XR, XL, CC, etc. may be added to the brand name of the drug to indicate such formulation. Generally, these products should not be chewed, split, crushed, as doing so may disrupt the release mechanism. The top figure on this slide depicts the GITS or gastrointestinal therapeutic system, wherein a laser hole in the outer shell of the tablet slowly releases drug. The empty shell will be expelled in the feces, so patients should be educated about this. Please educate them. As a pharmacist, I hated when patients brought in the shell fished out of the toilet. The graph in the lower portion compares the concentration versus time curve for rapid release formulation to a sustained release. Note that Tmax is delayed and Cmax is lower for the SR, sustained release formulation. Another protective formulation is use of enteric coating that dissolves in the more alkaline pH of the small intestine. This slide depicts several of the many ways that drugs can interact at the level of oral absorption. Please don't memorize the examples, but you should know that pH and ionization interactions may occur. For example, when you take an antacid, there may be adsorption, changes in gut motility, chemical interactions, alterations in active transporters, and alterations in enzymatic catalysis in the gut and the liver. We'll be talking about that a lot more soon.